Welcome to PharmacyToDose, the critical care podcast. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. Quick read from our ad from our sponsor, QXMD, before we get started today. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out Read for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. Well, everyone sit back. We are certainly in for a treat today because I'm joined by Craig Beavers and the Cardio King. Now, this is not a nickname that he gave himself. This is a nickname that I have given him. But we are discussing antithrombotic and anticoagulant therapy with cardiac devices. Now, Craig Beavers is a cardiovascular clinical pharmacist with the University of Kentucky Healthcare, the director of cardiovascular services with Baptist Health Paducah, and an adjunct assistant professor for the University of Kentucky College of Pharmacy. He's also the current chair of the American College of Cardiology's Cardiovascular Team Council, amongst his many, many other activities. And not only is Craig one of the most accomplished, intelligent, just overall awesome pharmacists that you will meet, but he is one of my earliest and biggest mentors. I am absolutely not where I am today without him, and it's an absolute joy to have him on the pod. Craig, how in the heck are you doing today?
I'm doing great, Nick. I'm thrilled to be here, and I'm feeling a little modest with the commentary. I don't feel like I deserve any of the commentary that you just provided, but I think I learned tremendously from you, and it's always exciting to see, a trainee go on and do amazing things such as yourself and become so accomplished. And those are always the most exciting and more rewarding aspects of being a part of this community of pharmacy and the greater good of clinical pharmacy from that perspective. So I'm excited to be here and thrilled that you thought about me.
Yeah, absolutely. And I think that it's something when you have, because for those who, I'm guessing there's probably tons of people who don't know. So when I was a first year resident at TriStar Centennial Medical Center in Nashville, Tennessee, Craig was my mentor and ultimately the director of the PGY2 cardiology program there for a short period, but that's where our paths kind of passed, and we were able to work with each other. And I think when you have really good mentorship or really great people working with you, you feel even more obligated and you really want to give back to the profession. And I feel like that's part of why I have this hope and being able to give back to some of those things. I think that all started from then.
No, I guess that it's nice to see people dream and come to fruition. So this is an awesome experience for the community, and it's great to be able to share different knowledge and clinical skills and aspects and how people do things. And I think it's amazing we have this avenue. So thank you for doing this.
Yes, and we're even trying something new today. So, Craig and I will still have more of like the classic Q&A towards the end, but the beginning and kind of the bulk of our discussion is going to be more of like case-based. So where, we introduce cases and kind of ask questions or figure out, what we should be doing based on those. So we're always looking to try new things, and I think this is kind of a perfect type of topic to try it out with. So listeners, as you're going through, if you have feedback, please, this is one where any and all would be greatly appreciated as we try this new kind of format. So with that being said, let's kind of get started here. So we'll introduce our patient here. So MH is a 55-year-old male who presents complaining of, feeling of chest pain. He's confused intermittently and has cold and clammy skin that his wife tells us it's been happening for about the past 36 hours. His presenting vital signs include a blood pressure of 74/44 millimeters of mercury with a heart rate of 120 beats per minute. Now, based on this chest pain, he's in concomitant cardiogenic shock, he was taken to the cath lab. Now, he has clean coronaries. They didn't find any type of lesion or anything, and he was subsequently taken to the CCU for further management here. Now, as we introduce MH, mechanical circulatory support is commonly used to help support kind of cardiac function and cardiogenic shock, and we'll discuss many of these in detail throughout the episode. But Craig, what are some examples of mechanical circulatory support devices that we may see used in practice, and when are we typically seeing these used?
Yeah, so there's a wide spectrum of agents that you can use, and depending on the scenario and what you're trying to accomplish. I think classically, if you think about our older or more common agent that you look at, and these are obviously when you're thinking about supporting cardiac function or ventricular function, these are non-pharmacologic agents clearly, but you're thinking about the intra-aortic balloon pump, or the IABP, has one of those agents on the far end left of the spectrum. And as you progress forth, you think about more contemporary devices such as the Impella or the percutaneous ventricular assist device. And there's a variety of different iterations of that particular device that allow for different volumes of support in terms of cardiac volumes that is offloaded. You can think about the right ventricular support that they have in existence in one of their new devices. You can think of kind of the tandem heart device that is available. And then, you can augment or use independently and sometimes in conjunction. You can think about ECMO as another degree of the device. And I don't think we'll have time to fully get into ECMO, which is a separate loaded topic from that perspective. And then you can move on to, these are agents that you can use to support for an acute stage or as a bridge, depending on what the course of the patient is. And then you think more durable ventricular assist devices is a separate topic as well.
Yeah, you hit the nail on the head with the fact that I think ECMO is we're not going to really talk about that today because that can be and actually already has been a previous episode with Amy Zerba, one of our other colleagues. So for anyone interested in some of that, definitely go back and listen. But we'll be focusing, I think, on a lot of those kind of devices that you named as you were kind of going through some of the progression there. So MH, he's coming to the CCU. He's got this cardiac index that ranges from about 1.6 to 1.7, and his past medical history is significant for diabetes and PVD, peripheral vascular disease. And the cardiology team is discussing his cardiogenic shock management, and they're leaning towards placing an intra-aortic balloon pump or an IABP. So, Craig, how does an IABP work? And are there any relative or absolute contraindications that we would keep in mind as we're kind of evaluating the appropriateness of these therapies?
Sure. And, obviously, it's important as a pharmacist just to have a general feel for what these agents do or how they work and what their contraindications are. Often we're not immediately the person helping make these decisions, but it can help you understand, is this the right thing to do, or how would I treat or do things differently? So the IABP works on the principle of counterpulsation, where during left ventricular diastole, diastole, the IABP is inflated, which increases the diastolic pressure, and that helps augment the flow to the coronary arteries in the great vessel. So you push, blood into that coronary artery tract. It can help in that particular area to help assist with perfusion. But conversely, during systole, the IABP is deflated, and that creates a void that helps suck out that blood or suck out that volume and offload the heart. And so it kind of helps work through those different pressures and remove the left ventricular work and decrease that afterload. And ultimately leads to lower oxygen demand and provides the support. The unfortunate piece, and when we talk about that spectrum, we don't get a ton of volume offloaded, relatively speaking, when you think about our other devices that exist. You're talking about maybe 1.5 ml or liters, when you think about that. And so, it doesn't provide the maximum capacity, but in some instances it may be all that you need from that particular perspective. The historical or the absolute contraindications that occur with this is, if you have really any aortic disease, that is mostly an absolute contraindication, especially regurgitation, if you have stenosis or stomach stents that are there. that can be problematic. And, just thinking the mechanism, you can definitely worsen regurgitation, and that is not advantageous to what you're trying to accomplish or other aortic issues from that perspective. Now, when you think about relative contraindications, a lot of those have to do with some of the historical perspectives of how the balloon works. Clearly, it's a catheter-based therapy. You have a double lumen catheter with a balloon that's attached with helium and a console that kind of works through scanning the various different rhythms in the heart processes to determine when to inflate and deflate, and it does that in accordance to kind of what it's sensing. And historically, we have used these giant catheters, and over time, we've gotten away with doing some of those. But historically, if you think about the risk and where we're going to go with this, and thinking about some of the pharmacotherapy, is if you have peripheral vascular disease, that can sometimes be problematic simply because you're worried about that thrombotic sequela that can occur with that, or an aortic aneurysm, or if you've had major atrial reconstruction surgery, you don't want to kind of mess or blow that up. And so that's where those are kind of relative, but clearly if the benefit outweighs the risk, and especially since now that we're using somewhat smaller catheters for the management, the risk theoretically would be lower. That covers most of the contraindications.
And it makes sense, a lot of the things you said, like a lot of like an aortic disease, or you have big, regurg, is that is going to go in direct conflict with kind of the counterpulsation and how the IABP works. So at least mechanistically, it's helpful that it all kind of flows and makes sense when you understand how these devices work. So
yep.
Are there times when a balloon pump would actually be preferred to management compared to other devices?
That is a loaded question. And the fun things to think about with these devices is, there's a lot of gray area with them. If you really think about how they were approved and put on the market and the roles that they've used, and just overall how management strategies have changed, you could argumentatively say, when you look at the bulk of the data, and more contemporary practitioners argue that maybe we shouldn't ever use IABPs, and there is some data that suggests they do not clearly improve mortality. They could actually increase mortality depending on the scenario. But I do think there are some opportunities for, it's very common to use. People have some familiarity with them, and it can definitely be used in facilities or with patients that you need a little bit of augmentation. You may need to transfer them to a higher level of care. A lot of facilities can be familiar or have used an IABP because they've been around for a long time. It can be a device that's placed at bedside. So I think if you're trying to use it for a quick temporizing measure, sometimes in the OR they'll use them for a brief time. And a lot of times if you're thinking about some instances when you're not even trying to use it to afterload your heart, but you're thinking about somebody that you're worried about getting myocardial perfusion, there may be instances where you could use it in that particular perspective. But really, when you look at the data, and this probably goes forth with all the devices currently, and lots of debates about what are their true benefits and costs, it's probably not something that you immediately want to, in this day and age, go to first, but you will see them commonly for the exact reasons I said, is that a lot of hospitals have them, are very familiar with them. They're relatively inexpensive compared to some of the other devices, and they allow you to at least provide some support till you figure out where you're going and what you're doing.
And it sounds like a lot of these devices and their use may be more driven by anecdotal experience from your physician team, potentially, compared to maybe like published research or evidence in that same kind of field. Would you agree with that? Or
absolutely. I would agree with you on that. I think you may see some practitioners who have very familiar experiences with the IABP, and that may be their go-to from that particular reason. I think or you may have people that come in on them, and rather than go through the effort of changing them, depending on what the course of care is going to be, they'll just leave them on them and then, just prioritize that patient sooner rather than later, or whatever that may be, to manage the IABP. So I think it's, you look at the totality of evidence, you're like, it doesn't look very good for the use of these devices, and we still use them, but I think that's, it's multifactorial why they're still used and what could be the reason that is driving that. So it's not as straightforward from that particular perspective, but it's one of those things that as we get better data with other strategies, people may defer in that particular means. But I think the other thing that we do differently compared to when maybe we used to use them more commonly is we definitely have a better grasp on how to, especially in acute coronary syndromes, how to manage people and take them sooner rather than later, and decrease the risk of having all this myocardial dysfunction in some instances. And so, I think overall we've moved in this different trajectory, and it's, okay, it used to be we couldn't do a whole lot, right? And so this was a way of mitigating some of that. So.
And I think that was an important point, because I think especially as you're learning and getting exposed to all these, you may read these studies or kind of review articles saying, maybe it's falling out of favor, but then in your hospital, you're seeing tons of balloon pumps and it might not add up. So I think that's a really good clarification point, and probably can some of this information, and we'll cover this as we get to other devices. I'm sure it goes over the spectrum of them and is not necessarily limited to just a balloon pump.
And I meant to say, and I want to correct something I said, that it supports obviously a cardiac index less than 1.5, but it provides about a 0.5 liter per minute per mil. I think I said 1.5. I got that inverse, or it's supposed to be the index, so your index is about the 1.5 range, but then it supports 0.5. So you really do need to have some native cardiac output to be useful with the IABP.
So ultimately, the CCU team kind of agrees that placing a balloon pump may be beneficial here, and so after the balloon pump is placed, the patient is then ordered to receive a fixed dose unfractionated heparin IV infusion. It's going at 500 units an hour, kind of a fixed low dose. And his APTT is kind of ranged from about 35 to 40 seconds over the past, we'll say 2 to 3 lab draws, with his baseline being, somewhere like 30 to 32. So in patients who are on balloon pumps, what anticoagulation is most appropriate? Is this kind of low fixed rate of heparin that's not really getting your APTs therapeutic, is that appropriate, or should we be really kind of pushing for maybe a therapeutic heparin infusion?
Yeah. So this is one of those areas that is fun to talk about, and lots of debate and lots of poor literature to support this. If you think about why we're even trying to use anticoagulation, clearly the two initial reasons with the IABP around that is the risk of limb ischemia, which more so has to do with, as we alluded to, the size of the catheter in the balloon and the blockage of perfusion that occurs from that. And then obviously the device itself clearly is not designed to be in the human body and touching circulation, and so it's a thrombotic risk in its own right. However, when you really look at the data around the risk of thrombosis, it's, the limb ischemia is very prevalent in the older literature. But then again, as we've started progressing towards lower or smaller catheters, you definitely see an improvement upon that. And the thrombotic rate is not all that high. I mean, it's there, but when you really look at the rate of it, it's definitely in the 5%. It's not a super high rate. So then this has brought up all sorts of discussion points around, do we even need anticoagulation? And I think the question you're asking, okay, so unfractionated low rate or therapeutic heparin drip. I think the concern is that as we get more around systemic anticoagulation and the risk of thrombotic events versus the risk of bleeding as you use a higher rate heparin, you're clearly going to increase your risk of bleeding. Now, that's historically what a lot of institutions have done, is to put them on some form of anticoagulation, whatever their normal protocol would be. You could use a lower dose heparin and a lower fixed rate, and that may get away from the risk of bleeding. But then if you're really trying to think theoretically, well, the goal of this is to prevent clotting, and you're never actually getting into therapeutic APTT or anything from that range, you're like, well, then what is the purpose of even doing this? And realistically, I think what it all comes down to is if the balloon is pumping at a 1-to-1 rate, meaning it's essentially inflating and deflating with every beat, then you really probably don't need anticoagulation. There's data to support that in some of the hip-based literature and other areas. So you could get away without doing anticoagulation. That decreases your risk and benefit in some instances. And if you really look at, there's some great CT surgery data that looks at a low-dose heparin protocol versus no heparin in the postoperative respect, and you don't really see these increases in thrombotic events, and you definitely have lower bleeding events. You could probably get away if you're using it for a period of time of 1-to-1 of not doing heparin. It's really when you slow the balloon down to 1-to-2 or 1-to-3 that your thrombotic risk probably becomes higher. And usually when you're doing that, you're trying to say, okay, is the balloon ready to be pulled from that perspective? And you may have heparin on board when it's running slower, but then you just bump it back to 1-to-1, stop the heparin for 2 hours, and then you pull the balloon at that particular juncture. I think that's the important part too, is if you're on a heparin drip, you've got to stop it for a degree or a period of time before you pull the balloon. So I think there are instances, especially if you're running at 1-to-1 and you're worried about bleeding and what's the risk and those pieces, it's definitely okay to not use anticoagulation. It's not wrong to use anticoagulation. I think it's just harder to look at and say there's good data that supports it, and as more and more literature comes out that maybe it shouldn't be used. Now, albeit the limitations of this literature is always like retrospective, single-centered kind of either or dual-centered, retrospective observational data, so you have to take it with a grain of salt. So really you're in this gray area, and, if you're a good practitioner, you can be savvy enough to argue both ways and understand the limitations that you can use it in your favor and against your favor, because that's kind of where you're at. It's like one of the biggest gray areas, and I think ultimately you're like, ultimately, do we even need to use these devices, or what are the complications? But I think, realistically, thinking about the fact that we use smaller catheters, if we run it at 1-to-1, the overall risk should be a lot lower. Now, clearly, if you have somebody who's clearly prothrombotic and they're clotting and you see visible clot, or there's things that suggest to you that things are going on, then you definitely want to consider adding anticoagulation therapy. Or vice versa, if you have people with these bleeds around the site and other things like that, and you're like, how are we going to manage through this? Because bleeding has its own consequences. You could most certainly feel okay not having heparin on when it's going at 1-to-1.
Okay. So I think you did a really good job of kind of explaining it, but ultimately it's really going to come down to the patient, and it's going to be a patient-specific decision for a lot of these, especially when there's any increased risk of either bleeding or kind of thromboses from the patient's perspective.
Right.
Okay. Well, we helped MH here kind of solve and answer some of these problems with the balloon pump. Now let's kind of introduce a new patient, PM, who has chest pain radiating to his jaw and arm. Kind of feels like an elephant is sitting on his chest. So his EKG shows ST depression. They appropriately call it a STEMI, and he's taken emergently to the cath lab. Now, he's found to be in cardiogenic shock due to this acute myocardial infarction, and in the cath lab, an Impella was placed along with 2 drug-eluting stents. However, when the patient left the cath lab, the Impella was still in place because his cardiac index was remaining low in the neighborhood of 1.3 to 1.5 liters per minute per meter squared. So, Craig, what is an Impella device, and how does it work?
Yeah. So the Impella device is a percutaneous ventricular assist device, and it works similarly to more like a durable LVAD, but it's a line that consists of an intravascular microaxial blood pump and a cannula, and essentially it works, to remove blood from the left ventricle. Or if you look at the Impella RP, it removes it from the right ventricle. But essentially, I think of it, and this is not 100%, I think of it like it's a big suction pump that's just sucking out the blood from that particular perspective, if you're putting it in very simplistic terms to think about that. And so, it's removing them removing the blood into the ascending aorta or the pulmonary artery, depending on, again, if you're talking about the RP, you're removing it into the pulmonary artery. And, you have all these different versions. You have the 2.5, which can do up to 2.5 liters per minute of removing a volume, the CP, which is 3.3 liters, and then 5.0, which typically is surgically placed in the aorta for kind of a large unloading effect that you needed. So it all depends on what your output, what you're trying to achieve. A lot of times they'll use these devices in patients with cardiogenic shock who are needing support during PCI or surgery, or they'll use it temporarily for these high-risk kind of PCI procedures, CTOs, et cetera, if you need some support or augmentation to get them through the procedure. And so the differences between them all are based on where it's inserted. Most of them are inserted in the femoral artery. The 5.0 is axillary. Inserted, the volume is different depending on what you need, and then obviously the RP is for your right ventricle. And in some instances, depending on the patient, what the risks are, you can use a right and a left if you need support from both areas. And you may use this, for example, to bridge patients to something more durable, whether that's heart transplant or a durable LVAD. And that's kind of what you kind of think through from that perspective, thinking about the different Impella. So it's all depending on what you're trying to accomplish, what the end game is, how much unloading do you need, what is the difference between the different agents and how they're used.
Yeah, I had one of the Impella reps when we were at my previous hospital, as we were getting these devices, they were having educational things, and they described it as the Impella works as a sub pump for your LV. And I thought that's one of the best descriptions of it, because
that's exactly how I think about it.
Yeah. And if you haven't got, for anyone who hasn't got a chance to see it, I mean, this Impella device is extremely small, and I guarantee there's YouTube videos where you can see, like, they put this motor in like a water bottle or like this big kind of area with water, and you see the motor. It's like a boat propeller almost. I mean, this thing is no joke in terms of the power that it has. So it for visual people, definitely take a look at some of the YouTube videos to kind of understand what we're talking about here. Now, when would so you mentioned the Impella, it's almost like a percutaneous VAD in a sense. Now, when would you use the tandem heart, which is a different form of this? When might you use this preferentially compared to like an Impella?
Yep. So the tandem heart is an extracorporeal centrifugal continuous flow pump capable of providing up to 4-point assisted cardiac output. And the nice thing about this device, it can be used in both the left or the right side ventricle for support. The cannula is inserted in a femoral vein and introduced into the left atrium by means of a transeptal puncture. And the blood is then pulled from the ventricle into the pump and returned to the systemic atrial circulation via the femoral artery cannula. And because of this unique cannulation, it allows the tandem heart to do some things that the Impella can't do. And the Impella, for example, is contraindicated due to its mechanism where it's located in patients, again, kind of like the balloon pump, with aortic regurgitation, aortic valve prosthesis, or aortic valve stenosis, or if there's an LV thrombus present. So if a patient has a big LV thrombus due to their MI in the ventricle, you can't use the Impella device from that particular perspective. But the tandem heart, on alternative, you could use it de novo in the sense like you could use it like an Impella, but the benefit for the tandem heart compared to the Impellas. If you have any of those situations where it's contraindicated to use an Impella device, you could use the tandem heart because of the way it works to pull the blood in the cannulation process. So it's not contraindicated in those, in those particular situations. And it works similarly. It reduces the LV preload, the filling pressure, and the wall stress, and the myocardial oxygen demand, and increases mean arterial pressure and cardiac output. So it's similar that it can be used for short-term and cardiogenic shock into the Impella devices. I will tell you, some sites may have more familiarity or use or access to Impella versus the tandem heart. So I think from a comfortability standpoint, more people may be aware or useful or have used a tandem heart. Not to be completely to think tandem heart's the most amazing thing. If you do have severe peripheral artery disease or bleeding risk and those things, it's completely contraindicated in that particular instance. And like I said, even though you can use it with a clot in the LV, if you have a left atrial thrombus, you can't use it there. Or if you have a VSD, a ventricular septal defect, it's kind of contraindicated in those particular instances. And I would still not, while you maybe theoretically can get away with it in the aortic regurgitation setting, it's pretty severe aortic regurgitation. I would definitely think twice immediately before doing it. Again, we're lucky as pharmacists, we don't have to make these decisions per se. But that's kind of where the differences are.
It's kind of a perfect lead in because so the Impella's in place in PM, and he additionally, right, you come to the bedside and you're talking to the nurse and you realize that he's receiving unfractionated heparin and dextrose in 20% water, D20W, in the purge fluid with an additional 400 units of IV systemic heparin infusing. Now, for those who maybe have not used an Impella before, that might have been a little bit of a foreign language, what we just talked about. So, Craig, what is the purge fluid for these patients, and why are we using dextrose and unfractionated heparin in this purge fluid?
Yeah, so obviously a couple of reasons. One is the device, clearly it's a motor. And if you think about any type of motor like your engine or a car, you have to do things to protect the engine of that motor. And so this dextrose-based purge solution, it flows through the Impella for a couple things, and it works in the opposite direction of the patient's blood flow. It tries to create a pressure barrier, to prevent blood from coming into the Impella, so you don't get blood and clotting going on the motor from that particular perspective. But the dextrose also helps coat it and prevent breakdown. You can't really use sodium-based products because it actually has been shown to demonstrate deterrence or cause problems with the motor. So you have to use the dextrose solution to not only protect but to prevent the breakdown. But the anticoagulation there is to create this. The anticoagulation is there to prevent, if there were blood to get into the chamber area, it would prevent thrombosis. But the dextrose and anticoagulation, the solution, the purge solution is there. It creates that barrier to try to prevent that from happening. And so that's kind of what the overall function of this is. And, there's a built-in pressure sensor device that helps us. It automatically adjusts that purge flow, and it can be anywhere from 2 to 30 mils per hour to maintain the pressure it needs, which is about 300 to 1,100 millimeters of mercury. And so it kind of, moves that to keep, the patency there and prevent that blood from going into the motor. And it's not there, that particular piece of anticoagulation is not there to provide a systemic anticoagulation. Again, like you think about with the IABP and any of these devices we put in, there still is a risk of thrombosis that you may get from having a device that is not supposed to be there. But this particular anticoagulation is there to really protect that motor. And the interesting thing is, you mentioned the D20. the dextrose concentration helps dictate the viscosity and the flow rate of the purge solution. And, if it's a lower dextrose concentration, that means less viscosity and there's quicker flow through the purge, which that is theoretically a good thing, but it can also lead to more heparin exposure. And so at the current moment, the manufacturer has recently changed, and this is a fun case to think about and look at. They recommend D5 25 units per heparin for now, and that was a recent change as of February of this past year. And part of that's just to kind of minimize that risk of overexposing patients, but also realizing that you don't need as much dextrose to be helpful from a protecting standpoint.
That is interesting, because I think most of us have our standard heparin being 50 to 100 units per ml. So kind of going away from that standard premixed based on that. That is interesting. I didn't know about that recent change.
Yeah, it's they snuck it in there. Of course, if you really think, that was right before we had all of everything that's going on in the world related to, not that they were trying to do it in this particular, juncture of time, but that was right when things were starting to get crazy, when that kind of release went out from that particular standpoint. So I'm not sure if, I think they're trying to get it out there and let people know that those changes have occurred, but just kind of be aware that they have recently changed that it should be 25 units per mil in the purge solution with the D5. So
yeah, it doesn't seem like it's a Friday news dump where they put that out there trying to have people overlook it. I agree. It's just a victim of circumstance.
I will tell you, I've had lots of conversations with the manufacturer, and they actually really want, and it behooves them to do this, they really want to make sure that people understand and support and have reason behind what the safety of the anticoagulation aspects are. And again, it behooves them because it makes their device safer, but they've actually spent a lot of effort trying to understand where the pitfalls are from the anticoagulation perspective, and how do we improve them, or how do we make people aware of them. I think the struggle with this is there's a lot of hospitals that use these devices that don't have, clinical specialists or people that have been trained in cardiovascular disease or critical care, or there are, pockets of the United States where they haven't infiltrated, these types of folks, and not even not saying people that work in a central pharmacy or have done just PGR1 aren't knowledgeable on that. That's not the piece at all. It's just when you don't deal with them regularly, and meaning what I mean by that is, like, if your hospital's only putting in one a month or one every other month, or, it's harder to have that familiarity. And so they spend a lot of time, they're, trying to educate and make people aware of all the things that need to be tied to this. So.
Well, yeah, it's just a little bit different, right? It's not like you're just getting asked a question about a standard heparin drip for someone with a DVT, right? This is somebody who they've got other things. It's more of a complicated process and issue, and so risks to the patient if you're randomly getting asked questions and you're not, right. High risk, low utilization kind of procedure or interventions can be the trickiest.
And even if you are trained and you're at a site that aren't using them regularly, there's still risk there. It's just, making sure that you have the familiarity and what goes into them. And I will say they have developed some great resources to help people practice cases and do things and think about them and so forth. So, they are trying to figure out a way to make it safe from that perspective. So
my experience with Impellas is that with the previous, when you would use the, either 50 or 100 units per ml, is that the APTTs generally tended to be a little higher, and you would have to cut the concentration of the heparin in the purge. But I think another question that may come up is for some patients is that, they have the heparin in the purge solution, right? And you're monitoring the APTTs or however you're monitoring that. We'll talk about that in just a second. But say it's running really low, and we're concerned that our APTTs aren't getting up, so we want to maybe start some systemic heparin in addition to that purge. So how do we go about, obviously we don't want to just start our therapeutic rate, but how do we go about trying to figure a starting kind of concentration? Do we have any tips or tricks for that?
Yeah, so I think this is kind of one of those areas that also, like we alluded to, it's not that it's a gray area. The manufacturer provides some guidance in terms of the fact that obviously, you should probably, still have some form of systemic anticoagulation if for some reason they're not low body weight, you're not getting enough heparin via the purge solution. Again, the purge is not designed to provide systemic anticoagulation, but some people end up getting some in the system that does lead to them being systemic. But, you do need to have some anticoagulation on board, given that you're having this device. And just to briefly talk about the risk of thrombosis, when you look at the data for that, it is also hard to grasp what the true rate of thrombosis is with these devices. And they're all over the board because, when these devices have been improved, the kind of major point of the study was not around how much thrombosis they were having. And of course, they've looked at safety in those types of things, but that again was not well defined. It's not consistent in what they were looking at and those types of things. So, we just know that there's a risk of thrombosis, and it can vary anywhere depending on what literature you're looking at. Can be anything from, case reports of 11 to up to 17 to somewhere in 30. It just very depends on what the data source that you're looking for. And so, you really want to have some anticoagulation on board to prevent some of those things if possible, if you're having some of the bleeding. So obviously we talked about, how do you pick a rate? Well, clearly, when you put the device in, they recommend giving an intravenous bolus of heparin starting at the insertion, trying to get your activated clotting time and an ACT at the time of 250 seconds or longer. And, if they got glycoprotein 2B3 inhibitor, it should be 200 seconds or longer. And then the manufacturer recommends after insertion, if they are needing or immediately afterwards needing systemic heparin, they recommend that you start and have a protocol that's 100, targets an ACT of 160 to 180 seconds. And that's what the manufacturer recommends or recognizes. But of note, they also recognize and realize a lot of people don't use ACTs as their normal monitoring parameter, and so they'll use either APT or anti-10A, and this is where it starts going downhill from what do you do and how do you do this and what is the way that you do it, an appropriate way to manage your, I think a lot of people will use their normal heparin-based protocols. Now this is where you got to be careful about what is your concentration of your heparin and the concentration of the purge solution, and really looking at those types of things from a safety perspective. And this is where it really goes into what are your systems of care, the processes of safety, and how can you value that and for it to be the most safe for you and the nursing staff and everyone involved. But I think the general point is you need to have a protocol in place that will help you target whatever you're going to target, and defining what that target is going to be and being consistent with it in terms of, all right, we're going to target an APTT at this, and we're going to be consistent at this, and we're going to start a systemic heparin at a full dose from that particular standpoint, and we'll do this. I think the key is if you're getting some systemic heparin, if you're ACT or you're getting some degree of heparin from the purge solution, you need to subtract that rate from whatever your normal protocol processes are. So, for example, if you happen to be somewhere on your protocol and they're getting, 12 units, especially getting 12 units from, heparin, and you're getting X amount from the purge, you need to remove that purge amount from what your systemic level is going to be to kind of adjust for that. To think that's the best thing to do. And again, the nice thing is the company has developed worksheets to help people with this from a nursing perspective. There's an app now that they have to allow people to say, okay, here's what my heparin is, here's what my heparin in the purge is, here's where I need to get to, what should I subtract out from this to understand what rate I should be running my heparin drip at from that particular perspective, trying to eliminate the bleeding risk. And I think that's where if you don't make those adjustments, you compound the amount of heparin the patient's getting, and that increases their risk for bleeding from that particular perspective. And so that's a pretty consistent message. I think the question that you alluded to is, do you do a low dose or low rate heparin versus a high rate? And, a little bit that gets into what you monitor and your target ranges for those. And that's a whole separate loaded question about, do you use anti-10A or APTT? Like I said, the manufacturer recommends ACT. Some people are using anti-10A, some are using APTT. There's not a good defined answer to this question. As you probably talked about in your ECMO podcast and so forth, and looking at that, some of the same issues that you have with ECMO in terms of coagulopathy and other things that occur, you can have that happen with the Impella device. So it makes it complicated to determine what is the best strategy to use, or you should use multiple different strategy, because we know anti-10A definitely measures the heparin effect from that particular perspective. However, I think the more important piece is whatever you do, you need to be consistent, and have people understand it and do the training from that particular standpoint. There's some data that shows if you use a lower anti-10A that which correlates with the lower APTT range, that you had more people in the therapeutic range, and you didn't see thrombosis, but there was still a decent amount of bleeding. So it may not be just related to the anti-10A. I think it goes to the variability in the tests that we use and how we measure them in those pieces. I think the more important piece is being consistent and being cognizant, and the whole team being cognizant of how much heparin they're getting, both between the purge and the infusion, and kind of, monitoring where those pitfalls can be. So it's one of those things you definitely can't just set it and forget it and just be like, okay, we'll just see how this is going to go. You have to kind of really be paying attention. And that's where my lessons are for that.
And it sounds like because if you've been keeping up with cardiac and anticoag literature, there's been fierce debates over anti-10As versus APTTs and the strengths and limitations of all of those. And it sounds like what I'm hearing is that you have not been hiding the answer from all of us. You are in the same place that we are, that we're trying to figure this all out.
Whoever figures that out will be the most, we will be very well regarded. And again, I think unfortunately, there's no perfect test, and that's kind of the problem. And maybe it's use multiple strategies, but I think it really just takes people realizing that you have to have some high touch with them, and which is great, because this is what pharmacists love to do. Is like, okay, we have drug therapy, we can monitor. How do we make adjustments? What can we do to prevent them? What are the things that put them at risk? And so I think that that's probably just as or more important than exactly what are the tests, because we know they all have limitations, and those, the situation for the patient is ever changing depending on how long the device is in and what's going on with the patient and things that can impact or affect each of those things. So it's not just a static situation.
Now, what do we do if a patient has hit? Can we use something like a direct thrombin inhibitor in the purge fluid?
Yeah, so that also is a fun area of debate, because the manufacturer has not studied or evaluated using a BTI or a direct thrombin inhibitor in the purge solution. Now, there is lots of case reports and literature that suggest that you could use argatroban or bivalirudin that appears for a reasonable duration, that it appears to be safe. Now, the problem there is we're talking about case reports or case series, so a limited number, so we don't really know what the true answer of that is. And they currently recommend, and this is where it always has, it's a hard pill to swallow, no pun intended for pharmacists, is when they have hit, they recommend that you run the purge solution without any heparin, but remaining with the dextrose solution, and then you use your systemic anticoagulation via the correct alarm inhibitor. And that's where it's a little hard when you're like, so you're telling me when I don't have hit, I have to put heparin in the purge solution and do all these things that put me at risk for anticoagulation issues there, but then as soon as I have hit, I don't have to have it in there. And again, I think these are things. Yeah, I think these are things that, the good news is I think, again, having asked these questions to various different Impella reps throughout my career and other people doing the same, I think that they're realizing, how do we work together to figure this out and think through this. So I think that there's going to be some things coming down the line that will help clarify some of these points. But at the moment, the recommendation is not to put a DTI in there. And again, there is literature that supports doing this, and they'll even provide you a nice letter that tells you about that literature from that standpoint. That you can do it. It's just, and then there's even literature about, again, not running purge, just doing the purge itself with no heparin, and it seems to be okay. Again, a lot of these things have limitations, that they're single case centers, but I think really when you're thinking about I always think about it, what is the duration of the device that we're going to be doing this for? How much longer we're going to be using the device? And clearly, if it's hit or you're suspicious of it, you have to anticoagulate them because it's a thrombotic event. So you're going to put that systemic anticoagulation on board, whether it be bivalve or heparin. But then you've got to really think about, okay, how much longer am I going to be using this device? If it's going to be a while, then do I really want? Do I consider putting in heparin the purge solution, or excuse me, DTI on the purge solution? If it's going to be a short term, maybe I can get away without doing it long enough from that perspective. I think the big thing is paying attention to those things and what's happening to the device and how you need to adjust course as it's being seen.
So great review and kind of discussion on some of our Impella key points there. Now let's kind of shift gears here. We got a new patient coming in, CP. She's a 64-year-old female. She has a HeartMate LVAD as a bridge to transplant for ischemic cardiomyopathy. And the team approaches you saying that they're concerned that CP is experiencing hemolysis. So specifically in LVAD patients, does hemolysis indicate that anything else maybe more concerning might be happening?
So that's a great question. And hemolysis, is very critical in things that we think of with our left ventricular assist devices. And we often are immediately jump to pump thrombosis. But you got to think there could be other factors that could be leading to hemolysis. It could be dehydration or an underfilled left ventricle, which kind of increases your inlet velocities. It could be stenotic or regurgitant valves, native or prosthetic, that creates some high jet velocities, or it could be if they've recently gotten transfusions or other issues or other things. It could be transfusion-related immune or non-immune mediated hemolysis. So it doesn't necessarily immediately mean that could be the case. Now, typically what we look for in labs is to maybe indicate hemolysis is you look at your LDH, but also look at your haptoglobin and kind of looking at that particular piece. Now, and so that's kind of the labs that we can use in conjunction, but then you would also look at other things that would maybe go in conjunction with that, looking at the clinical presentation. Do they feel unwell, or do they complain of fatigue? Are there alarms or device alarms or changes in the pulsatility index or increase in pump power that could be triggering things? So it's not just looking at the labs, but looking at the picture of the patient or their new heart failure. What are the things that are going on that, really could be important from that perspective? I also want to look at bilirubin, your total bilirubin, and your hematocrit rate hemoglobin, and then obviously things that you're looking at that could be problematic, your INR and things that you want to put in context. So those are some things you want to kind of look at.
So does our management, because one of the biggest concerns is like potentially like a thrombosis, right? With potentially hemolysis. So if that occurred in any patient who has kind of more of like a chronic type of LVAD, like a bridge to something, like a potentially, whether it's destination, transplant, what have you, does our management differ based on the type of VAD they have, or is it more of a kind of universal approach? They have a VAD, the type of VAD they have is maybe less important, and we kind of manage it with these specific principles, or does it really depend on the type that they have?
I mean, I think for the most part, generally speaking, it's pretty universal in terms of what your strategies are. Trying to troubleshoot what you think the problem is, kind of why you think that is occurring. I will tell you, when it comes to, using agents if there is truly a clot, you can confirm the clot, you're just suspicious that there is a clot there. There's very little data in terms of, what is the best cocktail in terms of troubleshooting this, whether you use TB3 inhibitor, whether you use lytics, whatever that may be. Clearly, you got to put them on some form of anticoagulation or increase the intensity of anticoagulation, and that might help as well. And so it's kind of troubleshooting those. But ultimately, if it's a large enough burden, unfortunately, the most optimal way to manage this is to remove the device and implant a new one. You can only do that so many times, and that's really determining, okay, if I remove this, should they go ahead and get surgery? Can we get them listed higher, whatever that may be? But I think universally, you troubleshoot and say, do I think this is a clot? What factors support thromboses? What things can I do? And again, a lot of these are kind of to help you either, if you're using anticoagulation, either to see if it will help clear it up quickly, and if not, what are my next steps going to be? And you really ought as well, if you are trying to use something, thinking about what your next steps are going to be, whether the device needs to come out or can they get listed differently, or that standpoint.
Now, later in CP's kind of admission here, she has an acute drop in her hemoglobin, and with the concern that she now has an acute upper GI bleed. Now, we'll kind of do the exact 180 of what we just asked. Does our management of bleeding for LVAD patients, does that change compared to how we might normally treat an acute upper GI bleed? Are we maybe more conservative with the device being implanted in these patients?
Yeah, so I think in general and not going in depth on this, you clearly do not want to, the knee-jerk reaction in a lot of the bleeds that you have in a patient without a LVAD is to, remove the offending agent, stop their anticoagulation, or, reverse it or do anything like that. I think in this instance, you have to look at, are there ways that I can kind of, provide that supportive nature for the patient, whether that be, transfusion, those pieces. Are there things that they're not currently getting that I could use to temporize or fix the measure, whether that's, doing a proton pump inhibitor infusion for the short period of time, figuring out, do they need, if they're on high dose aspirin, do they need lower dose aspirin? Do they need longer term therapy to prevent this going down the line? Further down the line, there's data that suggests that ACE inhibitors can prevent or reduce GI bleeds. But in the acute care setting, you can't immediately reverse it because you're going to put them at risk of thrombotic events and those types of things. So you got to try to troubleshoot it while you are providing that supportive care for the patient, doing what you would do in a lot of other contexts of managing a GI bleed or an issue, but then you're not, again, trying to salvage some of the anticoagulation effect. Does that make sense?
Yeah, absolutely. And it sounds like, if it got to the point where we felt that we got pushed between a rock and a hard place and we had to administer some sort of reversal, I feel like it would be the realm of a much lower fixed dose. We can always give more and kind of try to do the
Correct.
smallest doses to help kind
absolutely
of cessates
conservative as possible. And I think you have to have very clear intention what your goals are going to be and where you're going to go if you're reversing the anticoagulation. And you'll, if you can manage it without or during, that's what you got to do. And again, there's no like one answer for all these situations, but if you're going to reverse it, low, don't put them at risk of thrombosis. What are the next steps going to be? Is that going to be, are they going to surgery to get their device replaced? Which wouldn't happen acutely in NG, I believe, but it's really thinking about what are my next steps going to be if I do this, and now we have clotting, and thinking about that. But I think it's being very cautious if you can do things to manage or mitigate it without completely stopping the anticoagulation, or you can reduce the intensity. You're doing something for the period of time, but then obviously adding up things that you're not doing and what can you do to prevent it and those types of things. It's a real balance and struggle. So.
I mean, it really thinks it. I think of it similarly to kind of how we manage bleeding or those types of things in patients who have like mechanical mitral valves, right? That is reversing it is our last line solution. It's what we want to try to avoid. And it sounds like maybe not the same risk, but it's still ultimately we want to avoid that at all possible. Perfect.
Yes. It's not, I'm not saying it's off the table, but it is not the first thing that I'm reaching for. And the other things you can do is like think about, blood pressure control and just kind of looking at those things and doing endoscopic treatment. And, the other things that you can add are, octreotide. I think there's a whole pathway of things you can look at and think through to add and prevent and try to stop the bleed. If you don't have octreotide, desmopressin, those types of things. And there's even some data with thalidomide and so forth, and not to go in the full semantics of all these, but I think where you're going for is like, okay, do I reverse it? And you really want to not do that unless it's super life-threatening, right? Like it is like clearly the risk outweighs, or the benefit of reversing it outweighs the risk. And so, you're troubleshooting, you're doing, okay, have I done my PPI? Have I done my have I provided the supportive care and the transfusion? Do I need to do something else like octreotide or desmopressin? Do I need to go down the route of thalidomide? Long term, are we going to put them on an ACE, or do I need to change my intensity? Do I need to drop my aspirin? And then again, ultimately, if it's a life-threatening bleed, and you're going to have to do that. That's what you're going to do.
So our next patient this has been a busy day on service, I guess. We're recording this on a Monday, so it's a typical Monday, it seems like. But KJ, she's a 74-year-old female. She's got a recent diagnosis of atrial fibrillation, and she has a CHADS-2 VAS score of 3. So she's female, she's 74, and she has a past medical history of hypertension. And she's looking to avoid long-term anticoagulation because, in her words, she doesn't want that rat poison. I think all of us who've ever been in a Coumadin clinic have probably heard some of those phrases before. So we're looking for a long-term strategy here that doesn't necessarily involve anticoagulation. So kind of building off of KJ's case here, when would we look to use Watchmen devices?
Yeah, so if you aren't familiar with the Watchmen device, the Watchmen is a left atrial appendage occluder device, and it's not designed, if you are or are not aware, the atrial appendage is thought to be a large area within the atria where there's a large risk of clotting that we think of in atrial fibrillation that leads to the clotting and the stroke that we see. The problem that is outlined here is this device it's had a very interesting history in terms of its approval process and the 2 trials that were used and its risk of stroke. And, and I think part of that is the risk that we originally saw in the early trials was partially due to people learning how to use the device and put it in. And as we've gotten better at that and had success rates, some of those risks have decreased. But ultimately, the device was approved on the FDA, and essentially it has a very specific outline of what the approval for this is, and that's essentially for people who can't tolerate warfarin specifically or for their atrial fibrillary reduction due to concerns about the risk of bleeding. And so, if you really read the specific labeled indications to reduce the risk of thromboembolism and left atrial appendage and non-valvular atrial fibrillation or an increased risk of stroke or systemic embolism, so that's a CHA2 VASC of greater than 3 or CHA2 greater than 4, who meet the criteria for anticoagulation, who are suitable for warfarin but have appropriate reasons for seeking non-pharmacologic alternatives. So clearly they've had falls or risk of falls. They may have a little weaker indication for patient preference per se, but they have clearly a high risk of these thrombotic events, but definitely an equally high risk of bleeding from that particular perspective. And so that's kind of who the device is targeted for to be used, and that's when we kind of look to use it. And so usually, a lot of times when you look at documentation to get it paid for from CMS or other organizations, you have to really provide a clear reason why they have failed anticoagulation. And sometimes that includes, have you tried a direct-acting oral anticoagulant because the risk of bleeding is substantially lower with those comparatively. And there was a recent trial that looked at direct-acting agents compared to the Watchmen and found overall they were non-inferior to each other in terms of that, and clearly there's kind of a lower bleeding risk with the Watchmen device, but that's over a period of time and kind of looking at that, and so that trial wasn't designed specifically to look at the long-term bleeding risk per se. It was more designed to say, well, from a thrombotic effect, are they non-inferior? But clearly the key is if they can't tolerate anticoagulation therapy for whatever reason, and there's a huge risk, then Watchmen may be a suitable alternative after kind of that discussion. But I definitely would not, in her instance, I would want her to consider risk benefits and not immediately jump to the Watchmen, because it is a device. You do have to still do anticoagulation, warfarin for 45 days afterwards, and then an aspirin regimen as well. So it doesn't completely absolve you from anticoagulation for a period of time. And so again, it is a device that we put in that has risk.
I think that's an important point, is that it doesn't, in the short term, you're still using anticoagulation. It may just potentially be a solution for some patients more long term.
Right.
Now, there's a very kind of specific anticoagulation regimen that's FDA approved for the Watchmen devices. Is there any evidence for non-warfarin-based anticoagulation regimens here, or are we focused on kind of our vitamin K antagonists?
Right. So it was studied to do aspirin 81 milligrams daily plus warfarin for at least 45 days, as we alluded to, with an INR of 2 to 3. And ultimately, at 45 days around that point, you do a TEE, and if there's no pair-device leak, a large leak or anything that's there, then they go on DAP for 6 months, and then after that 6 months, you go on high-dose aspirin at that particular juncture. When, obviously, I alluded to trials comparing DOAC to the agent, the Watchman itself, but then alternatively looking at a DOAC agent instead of warfarin, that data is there. It's just very small or weak, and it's retrospective. And, I wouldn't immediately advocate for it unless there's a strong reason to do that at this particular juncture. And, there's data is all across the board in terms of which DOAC to use, for example. So it's not clearly been like they only have looked at this particular agent or that particular agent. And just as a side note, the reason that we're even doing this is because, like most devices, you have a risk of device-based thrombosis. It's clearly the highest in the first 45 days. Interestingly enough, that is based on a dog model where we get that 45 days from. So we actually don't really know if the human model is greater than 45 days. We just are extrapolating and say, well, in the dog model, about 45 days, it appeared to be to the point that it was endothelialized enough that we don't see the risk of thrombosis. So we've never really seen in a human model what the true rate of that is. We're just extrapolating based on the dog model and say, well, 45 days is what that was. So we'll just kind of go from here and use it from that particular perspective. But the function of this is to all, decrease that risk. And then obviously there's, operational based procedures that increase your risk of thrombosis. And that's where, we look for the paravalvular leak and those types of things to kind of help heal over. And as we've gotten better at doing the cases and the procedures, as I alluded to, some of that risk has gotten minimized or decreased over time. But then, clearly people have tried to look at, okay, can we use a direct acting agent to reduce the risk of device thrombosis instead of using warfarin? Or, for example, when patients may have thrombotic effects and they're still with warfarin or they can't keep them controlled, can we use a direct acting agent? And yeah, like I said, it's been studying 2 retrospective analyses that looked at kind of the first 3 months post implant. They were all the different DOAC agents that you can think of: dabigatran, rivaroxaban, and apixaban. About 30 to 40%. 35% on rivaroxaban, about 43 on dabigatran, 21 on apixaban. The traditional AFib dosing that you normally think of in all these patients. And the overall rate was low, 1.3%, and there's no risk of stroke. 1.3% risk of device-related thrombosis. None of those turned into stroke, and the bleeding rate was low. And you see that in one study. In another study, you see kind of like the very similar rate and very low risk of bleeding. And then you put this in the context of the PROG trial, which the PROG again compared DOAC to left atrial appendage, which is a completely different study. So in this particular instance, if you have a risk or they need one, you could theoretically do it. It's just not currently approved that way in the labeling. So you really have to consider who the patient is, what you're going to do, and monitor that from that particular perspective.
Even as someone who thinks they're extreme, this is a pro dog podcast here. The listeners, yeah. I've let them know. Even me, I am a little taken back at using dog models to do that. But sometimes ignorance can be bliss with some of these things. Once you actually find out where some of this info kind of comes or is derived from. So. We'll kind of wrap up our case-based questions here, and we have a couple kind of potpourris towards the end. But so TW is an 80-year-old male. He has severe aortic stenosis. He was deemed a non-surgical candidate, so he just underwent a TAVR and received the SAPIEN heart valve. Now, his follow-up echo is concerning per the interventional cardiology team. So after a TAVR procedure, transcatheter aortic valve replacement, what are common adverse effects that, especially in inpatients, in the short time that they're typically here, that we kind of look for and monitor for?
So obviously you alluded to one of those, and that's thrombosis. You obviously always worry about bleeding events. Stroke is very common early on in the thrombotic field, if you're thinking about that. And that's usually early on what you see in terms of stroke is not necessarily a full ischemic standpoint of like, oh, they've, what you see, is there a clot on the device and those types of things. Typically the stroke you're seeing is all procedural related. As you, manipulate the valve and put it in there, you break off material and it, moves through the pathways towards, the head and blocking the carotids and those types of things. So, early on you see that kind of thrombotic risk from that standpoint, and that's typically what you see. And then alternatively, you see the traditional things that you would see from a normal catheter-based procedure, femoral site bleeding, access site bleeding, risk of tamponade, and those types of things. So, if you really think it's your thrombotic risk that you typically see early on in a catheter-based procedure, and then your bleeding type access site risk.
So this may be the question that's maybe the hottest topic, or there may be the kind of the most debate about. But in TAVR patients, what's our preferred thrombosis prevention regimen? What will you commonly see patients receiving after this procedure?
And so, after procedure, you're definitely a loaded question as well, and lots of gray area. Currently, the recommendation is to do dual antiplatelet therapy for 3 to 6 months afterwards. The core valve did 3 months, the sapien valve did 6 months, and then afterwards you drop down to an aspirin-only regimen. Now, that data was clearly extrapolated from our stenting data, because if you think about TAVR valves, it's a valve like we think of a bioprosthetic valve, but it's on the frame of like a stent, a cardiac stent, and so that's where that kind of piece has gone from. Now we've tried to figure out the best way to manage this, because we do know that there is some, what we call, it's essentially like a microthrombus that is kind of a hyperaggregation type phenomenon. They call it HALT, that occurs with these TAVR valves that puts people at, theoretically you would think would put people at an increased risk of clotting. However, we're not clear whether that is true or not. The other risk behind that is not just, and then when I say clotting, the risk of stroke is what you're worried about. Is, okay, does this cause you or put you at predisposed risk for stroke? But the HALT also puts you at risk for, could the device clot off, right? And that's probably more problematic. Well, they're all problematic. So this hypoattenuating leaflet thickening, or HALT, that I was referring to, it could be problematic because, yes, that could break up and cause a stroke. It could also be problematic in the sense that, you don't want the device to completely thrombose. However, a lot of times, we see this development of HALT. We've not elucidated in the data whether that truly leads to problems down the road. And a lot of times when you treat them with anticoagulation therapy or something like that, it actually removes that HALT or decreases and from that standpoint. But currently, we're using ADAPT mostly around the stent thrombosis concept, or around protecting the stent. Not sure what the valve is. However, any data we've looked at using anticoagulation has not turned out to be positive, and that's mostly with patients who got DOACs. So we know currently the one trial we have, the Galileo trial with DOACs with rivaroxaban, did not show actually a benefit of doing the agent, actually potential harm or increase more death. Now, ironically enough, it was all non-valvular disease-related mortality, so we have some questions there. But a sub-study where they looked at the echoes, it did show that Xarelto or the rivaroxaban reduced the risk of that leaflet thickening or that thrombosis. So at the moment, we're not clear if DOACs are of value. We definitely know triple therapy is not helpful, like we've already seen in a lot of those instances. What is interesting is we have data that suggests that doing single antiplatelet therapy is maybe of benefit by itself. And there's trials these are all retrospective data, there's trials ongoing to better elucidate if that is true. Most of our data has been with clopidogrel. We don't have a lot of data with our newer P2Y12 inhibitors, so you're kind of subject or relegated to that. Not that you couldn't use them, but they all have more increased bleeding risk that can go in that direction. And then we have the newest data that suggests in patients with AFib who are, have other reasons to clot, that maybe warfarin is better by itself versus doing the warfarin and the clopidogrel of ADAPT therapy in that particular perspective. And so I think we're learning more and more about the different strategies. And so at the moment, the best thing to do is maybe DAP if they don't have any other indications, and then if they do have indications from an AFib perspective, you might be able to get away with a VKA from an INR 2 to 3 from that particular perspective. So the point of that message is it's all over the board currently, and there's a lot of trials coming out, even some additional ones in the direct-acting oral anticoagulant field. So I think we're going to learn more about single antiplatelet therapy and DOAC. And we're actually going to have data next week that's going to be presented at the end of August this week, actually, for the European Society of Cardiology meeting that is going to focus on some of these things.
That's just absolutely fantastic. And for the listeners here, like almost every single question that Craig has talked about here is controversial in nature. And when we say controversial, it's that there's not a gold standard trial kind of saying for some of these things, this is what we need to be doing for all patients in a standard of care. There's a lot of gray area, a lot of ways for interpretation and things like that. So just keep that in mind as you're listening and things, that this was, these were kind of loaded questions. So I appreciate you playing along here with us.
Yeah, no, it's just a lot of opportunity to, and what I really encourage people, because we don't have time to go into all the nitty gritties of the detail in the literature and the evidence, but I encourage people to look at the data, learn about it, and how to apply it to their particular situation or what they're dealing with, because it's all over the board.
Mm-hmm. Now, it's hard to cover everything with cases, so there's a couple kind of potpourri type of questions here to end things out. So from a pharmacy perspective, I think a question that will commonly come up that will instantly, people will have reactions to either positively or negatively, is the question of IV cangrelor, our parenteral antiplatelet agent. So my question is, in these patients who have devices, are there specific circumstances where we need to be doing or using IV cangrelor, maybe in those situations where people can't take their oral antiplatelets, or is this kind of using cangrelor with devices maybe outside of when we should be appropriately using this agent?
So I will definitely tell you they've not been studied for that, or cangrelor has not been studied for that piece. But I think really, you alluded to this, is really looking at the patient scenario and saying, we still need to give them DAP for whatever device or situation that you're looking for, and the only way that we can give it to them currently is to give this intravenously. And so I'm not saying never, but I will say that, there may be some unique situations where you want to consider that. And so, obviously the question then becomes, what dosing strategy do you use? Because the trial data is more of a short acute period in the cath lab versus, we have the bridge data, which is a lower dose, and that is where you're going to get kind of stuck debating what is the best dose or the most appropriate strategy. And there are no answers to that from that particular perspective. I generally, if I have to use it longer term in a non-acute setting, I hedge towards the bridge data, and that's all extrapolation from that particular perspective. And I think a lot of people do that. I think the real question ultimately becomes, what is the, how badly do I really need to use this, and how long ago? I think you have to ask a lot of questions, like when was the device placed? What's the risk of thrombosis at this particular juncture if we hold it? Kind of really doing your due diligence and thinking out loud about it before immediately jumping to using IV cangrelor.
So we've spent the majority of our discussion here talking about our mechanical circulatory support devices. And so one question I kind of wanted to ask, and I'm not sure if we know, do we have published data showing that some of these devices may, reduce mortality or help improve these patient outcomes?
So definitely for the Impella device, they're doing the large shock trial that they're enrolling for to help answer some of these questions. So we'll hopefully have a better feel for what the mortality reduction is with the Impella device in the future. But I think the struggle there is, again, these questions are not devised around specifically what are the pharmacies, the anticoagulation role of the pharmacist perspective from that standpoint. But if you think about any trial or device that you're putting in there, you're going to balance the efficacy off with the safety, and the safety component is bleeding, right? And thrombosis, and a lot of that's directed by the anticoagulation piece of that. So I think we can still play a role in understanding that data and that piece behind the data as it comes out. But there are going to be some trials looking at that from that perspective for the Impella device. I don't think there's not going to be a lot of balloon pump studies coming down the line. And then we definitely know that the TAVR data is very strong in terms of reducing mortality, and especially in patients who can't get aortic valve replacement surgery. And of course, there's other devices that are going to be coming down the line. Looking at right now, we have tricuspid mitral valve repair that is already in existence with the MitraClip, but I think there's pretty constantly going to be data for a mitral valve replacement that's going to be transcatheter and will probably have the same concerns and risks. And there's also tricuspid valve procedures coming down the line.
So are there Are there big studies on the horizon maybe related to focusing on like anticoagulation or antithrombotic management for some of these devices that we should be on the lookout for?
I think the biggest data that's coming out is all going to be related to our transcatheter therapies in terms of anticoagulation strategies. So you'll see a lot of movement there. I won't say that there's going to be large Impella-based studies, but like I alluded to, there's a lot of interest in how do we use these devices safer or more safely. And so I think there's exploration on what that looks like and what is the role and how do we monitor them and those types of things. So to be continued from that perspective. And then obviously with Watchmen, we're still learning a lot about that device and the use of it in iteration. So I think you'll see some DOAC trials and those types of things continually come down the line.
So Craig, what would be some general advice or things to consider or kind of big overarching points to kind of re-emphasize in regards to managing kind of antiplatelets and anticoagulants in patients who have some, a cardiac device?
Yes, I think the big thing is depending on the device and what you're looking at, there's thrombotic risk, there's bleeding risk. The data is mixed for a lot of them, but probably the most robust data we have is with, like I said, the transcatheter valves. And you really need to do your due diligence, the data, put it in context, ask questions, and do what you think is going to be the best for the patient.
Well, this was an absolute blast, and I can't have you come on without having a couple fun questions towards the end. So
Sure.
What is your favorite part about the Bluegrass State, Kentucky? Because you went to school there, you trained there, you now work there.
Yeah.
I'm guessing there's got to be something in the water or something that's got you bringing back.
Well, I think those things have changed throughout time. I think I definitely appreciate the bourbon, the basketball, the people. I think the people in Kentucky are some of the nicest people I've always have ever met. And obviously now I'm partially biased because my wife is from there and my kids have real relationships with the state. I think that has been a huge draw. But I definitely I think it's just the whole mentality. You have a lot of the best of both worlds, from urban to horse farms to hiking, and if you transverse the entire state, it's a microcosm of a lot of different areas and backgrounds. So it's pretty unique in my mind in that sense.
Because I'm guessing you've gone to some of the distilleries on the Bourbon Trail, maybe not done the whole Bourbon Trail. Is that a accurate assumption?
I've done a good portion of it. I think they all have their unique, obviously, flavor, and not just a pun in the sense of each bourbon tastes differently, and that is true. And there's favorites and those types of things. I think their tours are uniquely different. My favorite tour and experience, I think, is the Maker's Mark tour. Mm-hmm. But I do love the Buffalo Trace Distillery. But I think they're all different in different regions and areas, and so it's I think that's the fun of going on some of these adventures in the state. So.
Now, if anyone has had the pleasure of working with you or, hearing you speak at kind of a local or national conference, most people would see that you wear and prefer bow ties over neckties. Now, that wasn't always the case. So what's your story on how and why that changed and why you prefer bow ties?
So I started in college or in pharmacy school. I just was going to learn how to tie a bow tie based on a bucket list item. So I taught myself how to do it on YouTube. And at that point, I was just wearing them casually here or there. And then probably around the time, Nick, maybe you're at Centennial or somewhere, maybe before that, I was doing chest compressions on a CT surgery patient, and I was wearing a tie that day. And my tie went into the sternal limb. And at that point forth, I was like, bow ties don't have this problem, and I will forever go forth and wear bow ties, and if I have to. That way, I can still look nice, but not be creating an infection control risk by wearing a necktie. And so that's kind of where we went down that trajectory, and here we are still wearing bow ties.
What was the look of did other people recognize that happened? Do you even know?
Yeah, no, I mean, they literally saw me take it off and immediately put it in the biohazard bin, my tie. I was like, this is not going to work. So, but, I was, it's one of those things I was like, I will do chest compressions. Like, we were needing people. So I just jumped in there and was going to town. So, Michael Scott staying alive style.
I make all my students, when we do ACLS, I make them watch that clip. I think it's just so chaotic. It almost gives them a glimpse into what a code can be sometimes, just pure chaos. But that is, I'm glad you shared that story, because you told me that when I was a resident, and it makes me laugh so much. And for those who haven't tried to tie a bow tie, the fact that you learned it, you taught yourself, is so impressive, because actually trying to tie it is so hard.
It's all determination. So if you're determined to do something, set your mind to it. So.
Well, thank you so much for joining me.
Yeah, no,
today,
thank you.
Craig.
This has been a pleasure. I'm so excited to be here.
Yeah, I feel like this was a masterclass, and I had an absolute blast talking with you. Now, are you on Twitter, or how can the listeners reach out to you?
Follow me at Beavers, Beavrs, PharmD, all one word, lowercase, at Beavers PharmD. That's who I am on Twitter. I try to post regularly. It's a great resource if you haven't started using social media to connect and network and keep up with things and events and everything going on. You should definitely invest into it.
Oh, I really appreciate it. Thanks again. It's always great talking and catching up with you, Craig.
Yes, sir. Anytime. You'll have to come visit us in Kentucky.
Yes. Mark it down. I definitely agree with that.
All right.
I want to give another massive thank you to Craig for joining me today. And then, also want to give a massive thank you to you, the listeners. This podcast obviously doesn't exist without you. Please send me feedback, both positive and negative, as well as any guest or topic ideas. As we said, tried a little bit of a new format, so definitely let me know what you think. Did you like it? Hate it? Would you tweak it? So Twitter, Instagram, at PharmacyToDose, that's TO2Dose, or via email, PharmacyToDose@gmail.com. And then as always, on our website, PharmacyToDose.com, you'll find show notes as well as a reference list, and those links are available on the website and are also embedded within every episode description. And so until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.